year of training at the additional year of training at Thomas Jefferson University in Rothman Orthopaedics in Philadelphia, where I did a combined orthopedic and neurosurgery spine fellowship. And that's where I really got introduced to a lot of spinal deformities. After fellowship, I practiced at the University of Illinois in Peoria, Illinois for 16 years, and spinal deformity surgery was a large portion of my practice. So what I do is I evaluate and I treat patients for various spinal conditions, one of which is spinal deformities, and evaluate whether surgery is a good option for treatment, and then obviously do the surgeries for patients that we feel is indicated. And after presenting the patient with various options, and it's kind of a mutual decision, to proceed with a surgery of this nature, with a deformity surgery. So conditions I treat the entire spine from the neck, basically from the base of the skull down to the lower back. Radiculopathy is one of the more common uh, issues that I treat. Radiculopathy is a pinched nerve, and many patients with scoliosis will have symptoms of a pinched nerve. Myelopathy is damaged spinal cord that usually does not pertain to most patients with scoliosis. Pretty rare for patients with scoliosis to have an issue with their spinal cord being compressed. Tumors of the spine, I really enjoy spinal oncology, and then spinal deformities with scoliosis being a large part of that. I performed over 1,000 scoliosis surgeries in my career. And I can say I've definitely gotten much better since my first or second year in practice. Have become more efficient, have become wiser, and we've developed some new things in those 16 years that make these surgeries safer and more efficient. So in terms of our spinal anatomy, the spine is comprised of a number of different vertebrae, about 24 vertebrae. You have 7 in the cervical spine, 12 in the thoracic spine. You also have 5 in the lumbar, and then you have a sacrum, which really is joined together, but they start out as individual. They're named for the individual vertebrae. So you have a sacral 1, a sacral 2, a sacral 3, and a sacral 4, and then you have your coccyx. But most of the flexibility is in the cervical spine and in the lumbar spine. And then between each of these vertebrae, so through the canal is the spinal cord, and then between the vertebrae are nerves that are leaving the spinal canal. And those nerves go down to supply muscles in the arms and the legs, so it allows us to move, also provides sensation. So a pinched nerve will also oftentimes cause pain in the distribution of sensation provided by that nerve. So a patient with a pinched nerve in the lower back would oftentimes have a buttock pain, and then the pain will travel down in various locations of the leg depending on which nerve is involved, and that term is sciatica. So many patients with spinal deformities and scoliosis that I treat will have sciatica. So here's what we call an intervertebral motion segment. So we have two vertebrae in the joints between those two vertebrae. Hopefully you can see my arrow here. So we have an intervertebral disc here in the front between two vertebral bodies, essentially a shock absorber for the spine. We have what are called facet joints in the back that allow for movement, but restrict movement in certain ways. And then we have a foramen here. That's where the nerves are going to leave the spine. Oftentimes, that's where a nerve is going to be compressed in a situation of scoliosis. So in terms of the function of the spine is for movement and to support the weight of the body, and then protect the spinal cord and protect the nerves that are passing through the spine and passing out of the spine. So what is scoliosis? So scoliosis is actually a three-dimensional deformity. When we think of scoliosis and measure scoliosis, we measure it in what's called the coronal plane, which is basically side to side. So if you're standing up, this picture here on the right is an X-ray, and we see that that patient has curvature there in their spine. So we would measure the angle of that curvature and have a degree of curvature for the scoliosis in that plane. So there's a number of different causes, from idiopathic, and that's probably the scoliosis that most of us are familiar with. Um, that is the type of scoliosis involved in teenage girls, most commonly as the spine is growing, due to factors that we don't entirely understand. The spine curves during that growth phase. and can really accelerate during that growth phase and be a problem for some of these kids. Congenital, so some people could have vertebrae that aren't formed properly. They could have a half a vertebrae. So instead of their vertebrae being a rectangle, their vertebrae is a triangle. So you can imagine that ends up causing a curvature there in the spine. Neuromuscular, so this might be a kid with cerebral palsy or a young adult with cerebral palsy. The damage within the brain causes um, issues with one side of the body. So there's a weakness on one side of the body, and as a result, the muscle stresses and strains are abnormal and result in scoliosis. Degenerative. Degenerative is probably the most common variety that I treat, both non-surgically and surgically. This is the type that we see in adults that occurs with an aging spine. So degenerative degeneration occurring in the spine leads to scoliosis. Post-traumatic, so you could have a fracture occur in the spine that could result in scoliosis. And then iatrogenic. So iatrogenic is a term that basically that medicine, a surgeon, a physician, causes a scoliosis. So there's spinal surgery. So oftentimes I'll see a patient's had spinal surgery with a laminectomy or something where we're trying to decompress nerves without putting in screws and rods and doing a fusion. And in some instances, that decompression can destabilize the spine and result in scoliosis. Can be also occur in patients that have had prior fusions where the screws and rods aren't placed in appropriate alignment that can lead to deformities occurring adjacent to that fusion. So of the two kinds, it's in my practice and adult practice, most commonly what I'm seeing is degenerative, and then iatrogenic is probably the second most common. So as I mentioned earlier, degenerative, it weakens the spine due to arthritis that leads to the scoliosis. Many patients with a degenerative scoliosis that I see have what we call a leg length discrepancy. I think there's a typo in there. I should say leg length, not leg length discrepancy. So as one leg is shorter than the other, your pelvis is asymmetric and your spine has to curve above that to compensate that for that so that someone can stand straight upright. If the spine was maintained straight, then the person will be leaning off to one side. So with a leg length discrepancy, it results in a compensatory scoliosis in the lower back, and that can lead to further degeneration occurring in the spine. And then iatrogenic, as I mentioned earlier, it weakens the spine and can result in scoliosis. So here we go. We have degenerative. So here we're seeing an MRI scan of a patient with a degenerative scoliosis curvature here. All this patient's discs have degenerated. Their facet joints can be degenerated, and gravity is working against them, basically trying to bend them in half as their spine weakens. Here we have a poor bone quality. This patient has probably osteoporosis. This is some cement that was placed in a vertebrae to treat a fracture. As a result of the fracture, there's weakening of the spine, and then the person is leaning forward, developing a deformity. This isn't actually scoliosis. This is what we call kyphosis with a leaning forward. Here is progression of a pre-existing deformity. So patients with idiopathic scoliosis as a teenager, a lot of them go through and do not need a surgery. Their scoliosis and their symptoms not severe enough to warrant a surgery as a teenager. But as they get into adulthood, it can lead to abnormal forces and degeneration occurring within either that scoliosis or below that scoliosis that can lead to further problems. And then, as I mentioned, iatrogenic. So here's a case where a surgeon put basically straight rods in where they should put a little bit of curvature in. As a result, that patient develops an issue up above that and a severe deformity that we call kyphosis. So in terms of degenerative scoliosis, the most common adult scoliosis, this is due to spondylosis, and spondylosis is just a term that means spinal degeneration. And this type of scoliosis commonly presents with both nerve pain or sciatica, as well as back pain. So for this individual here in this x-ray that we see, this patient would oftentimes have scoliosis here on the left side of the picture is the right side of this patient's body, and the nerve tunnels will get closed off due to the scoliosis, and they'll develop a pinched nerve where the nerve's trying to leave the spine and have severe sciatica as a result. Spinal stenosis, so some of these patients will present with spinal stenosis, which is a narrowing in the center part of the canal. So this is an MRI scan here. We're seeing stenosis where there's compression on these nerves as they're passing down through the spinal canal. Here's an image depicting, so here we see the nerves. Here's the area of stenosis or a constriction in the spine. And that can produce symptoms of pain that travels into one or both legs. So common symptoms associated with adult scoliosis, many of these patients have back pain, although not all. Many patients will present to me as a surgeon when they have sciatica or radiating pain in the legs, or they're noticing postural changes. So as the scoliosis, the deformity gets more severe due to various factors. Sometimes patients have trouble standing upright, so their head and their shoulders are no longer symmetric above their legs and their pelvic bones. So they're leaning off to one side or the other, or leaning forward. And these stresses of leaning off to the side or leaning forward produce issues because the muscles, the biomechanics in the spine is best designed when we're standing perfectly upright. So if you start altering that, the muscles fatigue and it produces more back pain. Many patients are going to present to my office and not be aware that they have scoliosis, not until we're doing x-rays in the office. A lot of these patients, most patients are coming with an MRI scan before the appointment that shows that there's nerve compression. But then when we get to the office, we're doing x-rays to look at the alignment of the spine, and oftentimes scoliosis might be discovered, and many of these patients weren't aware of that. In terms of our options for treatment, so it all depends on the patient's symptoms and severity. Some patients have mild symptoms, and we can just say, hey, something you could just watch, or you might want to try a Tylenol, some activity modifications, some ibuprofen. So NSAIDs is oftentimes consideration for many patients with back pain and sciatica. Um, but NSAIDs aren't for everyone. So if you have issues with your kidney or heart disease, you'd want to check with your family doctor, your primary care physician before using some of these medications because there could be side effects. Steroids can be used for the treatment of nerve irritation or back pain. Physical therapy is often tried for most patients before considering any spinal surgery. Epidurals, so this is a procedure, small procedure done by a non-operative spine specialist. Either there can be a pain anesthesiologist or what we call a physiatrist. We have a couple physiatrists within our office currently that do a number of these injections to try to relieve sciatic pain and sometimes back pain. A TENS unit, so this is a device that you wear that can help block your perception of pain below that area. So it's an electrical device, gives you kind of electrical stimulation. It can confuse your spinal cord and your brain about pain. Facet injections, again, this is another procedure that can be done by pain doctors or the physiatrist to try to help with back pain more than sciatica. And then, of course, there's surgeries. So goals of deformity surgery are to decompress nerves producing symptoms. So if a patient has sciatica, we want to make sure that we're getting the nerve decompressed that's causing the sciatica. So we're in terms of decompression, what we're talking about is we're removing bone and structure from the spine where there's a pinched nerve. And sometimes that's important. So depending on what structures we're removing to get the nerve decompressed, then we might be concerned that there could be progression of that deformity. In other words, we could be weakening the spine. So there's different ways of doing decompression. Sometimes we can consider some small techniques and minimally invasive techniques that allow for nerve decompression while preserving as much stability as possible in the spine. But many patients with scoliosis, this can be limited. Stabilize the spine. So we want to make sure that one, we're not creating instability. And then in situations where we're concerned about instability, we're oftentimes stabilizing the spine. By stabilizing the spine, I mean placing screws and rods that hold the spine in position. And often doing a fusion where we're trying to get these bones to grow together instead of being individual vertebrae, we're trying to get them to grow together to stop movement across those areas. And then, of course, we want to correct or prevent any progression of deformity and correct the patient's, most importantly, we want to correct the patient's postural issues. So if a patient's leaning off to the side or leaning forward, we want to correct that so that after surgery, the patient is standing as perfectly upright as possible to improve their biomechanics and help with back pain. In terms of our imaging, we are oftentimes obtaining what we call scoliosis x-rays, where we can see the entire spine. And this really is important when these deformities are very complex, and one surgery could lead to another if you're not thinking ahead and thinking of deformities occurring in other areas of the spine. So it's important that we see the entire spine in two dimensions. We want to see a side view like this, and we want to see a front view so that we can effectively do the best surgical plan to address the patient's spinal deformity. When we measure these angles, we measure what's called a Cobb angle, which is basically an angle between the vertebrae. So these are vertebrae here. We're looking at an end plate, so we see that we draw a line off that vertebral end plate. And here, where we see the maximum curvature, and then we're measuring that angle. So for this patient, that angle measures it at 29 degrees. So mild scoliosis is something going to be less than 20 degrees. Moderate scoliosis, it starts getting up to 30 degrees. We're pretty worried. More severe scoliosis can be on the order of 50 to 100 degrees. So a lot of variance in these deformities. Then there's something we talk about in terms of balance. Like I said, when we're done with surgery, we want to have patients standing perfectly upright. We want their head and shoulders symmetric above their pelvic bones. We don't want them leaning to one side or the other side. So uh, coronal balance is a measure. We're looking at the patient's essentially the upper part of their body. We drop a line down from the seventh cervical vertebrae straight down, and we assess based on the center of the sacrum or the bottom of the spine, determine how much is this patient in balance or off balance, and how much we need to correct them. And then we're also looking at what we call sagittal balance. So we're looking at this. This is a view from the side. So is a patient leaning forward into what we call kyphotic deformity? So oftentimes scoliosis and kyphosis go hand in hand. Some patients will have the term a diagnosis of kyphoscoliosis, so they have both deformities, and we want to correct both deformities if they have that, so that when we're done with surgery, again, they're standing straight upright. MRI scans. So MRI scans is needed for every patient that we're going to do a surgery on. The reason for that is we want to see where nerves are decompressed and make sure we get nerve decompression addressed appropriately at the time of surgery. Some patients can't have an MRI. Some patients might have a pacemaker or another type of implant that prevents them from getting an MRI. There are other studies with either CT scan or something we call CT myelography, but we definitely prefer to get MRI scans if possible. So here's an MRI scan of a patient with a deformity. Reason we can tell the patient has a deformity is I can see these vertebrae really well. These kind of disappear. All of these cuts are straight up and down. So if these vertebrae are disappearing, they're off to the side. It means there's some deformity. And then we can see that there's areas of nerve compression. There's some nerves being compressed here as the nerves are trying to leave the spine. And we would want to address that, get that nerve decompressed at the time of surgery. So in terms of, when do we operate? So patients that have pain that's not improving with non-surgical treatments. So for a patient with a spinal deformity, almost 100% of the time, surgery is not going to be the first option because these are higher risk surgeries. These are larger surgeries. These surgeries sacrifice flexibility if they involve fusions. If they don't involve fusions, they involve risk for progression of deformities. So we want to try some other things before jumping in on surgery. So we're putting these patients through physical therapy. Oftentimes they're going to see a non-operative spine specialist, a pain doctor, a physiatrist, consider injections in the spine. Progression of deformity. So that can be an indication for surgery, but I would tell you it's pretty rare. Um, in my practice, if I have a patient that feels good and is very functional in life, it's very hard for me to put them through a big surgery to stabilize their scoliosis because they're having progression of deformity. So out of those 1,000 surgeries that I've performed, I may have had one that I perform for progression of deformity. So it's pretty rare. Most patients are going to come in with disabling symptoms before we're operating. Weakness. So some patients can have weakness occur due to nerve compression. If a patient comes in with significant weakness, then we might skip ahead and skip some of the non-surgical treatments and consider surgery. And as I mentioned earlier, these are large surgeries with higher risk for complications. So we typically are going to exhaust conservative treatment before we're jumping in on surgery for many of these patients. In terms of our surgical options, so options can include a decompression or laminectomy. I'm not a big fan of laminectomy performed through traditional techniques, so I would tell you that most surgeons are still using the same laminectomy technique that was utilized 70, 80 years ago when this surgery was first evolved, first came out. And that surgery involves significant removal of stabilizing structures in the spine and weakens the spine. So if you're doing that procedure in a patient with a pre-existing scoliosis, kind of a recipe for disaster. So a laminectomy can lead to more deformity, more scoliosis, and more pain. There are times where this can be performed, but I would prefer to do a minimally invasive technique, what we call an IPSI contra laminectomy that preserves as much stability while creating room for some of the nerves. It's not possible for all patients. Patients with foraminal stenosis, where the nerve is pinched as it's leaving the spine, it's almost impossible to get that nerve decompressed without destabilizing the spine. And for those patients, almost uniformly, they're going to need screws, rods, and a fusion. So a short segment laminectomy and fusion. So what I mean by short segment is we're fusing two vertebrae together or maybe three vertebrae together, but not addressing the patient's full spinal deformity. And this can result in issues. So if you're not careful with the way you're doing your decompression during the surgery, you can destabilize the adjacent segment. The patient could end up with worsening deformity and having another surgery within 1 or 2 years. So there might be some limited situations where we can do this. Um, and then there's long segment fusion. So with a long segment fusion, we're putting multiple screws and rods in and sacrificing many joints in the lower back, sometimes all of the joints in the lower back to fully size the patient's deformity. The nice thing about this is they never have to worry about a problem there in their lumbar spine again, but they can develop problems up above in their thoracic spine. This surgery will sacrifice flexibility, bigger surgery to recover from, but sometimes that's what's needed to fully address the patient's deformity and their symptoms. So in terms of what I've learned in my career, so when I started out in my career, I would just place screws. So by placing screws, I would look at the spine. I know the anatomy of the spine and where screws should go within the vertebrae. But the issue with scoliosis is there's significant rotation to the vertebrae. So these channels that we are putting screws down through, they're not in a normal alignment. They're far from normal, and oftentimes they're much smaller than normal. So about 5 years into my practice, I started utilizing what's called spinal navigation, which is essentially a GPS system. We have an intraoperative CAT scan machine. All of that imaging data gets fed into this computer system. There's infrared eyes in my operating room that see where the patient is, see the instruments I'm using, help us guide. I get to see the anatomy on a computer screen and helps us guide these screws in. This makes for safer surgeries, shorter surgeries, less blood loss, and better outcomes. Co-surgeons. So a lot of times I'm doing these surgeries with another surgeon. Oftentimes I'm a neurosurgeon in training. Uh, oftentimes use another surgeon, orthopedic spine surgeon. It's just nice having two surgeons together doing this case. It makes things more. It's not every case. I still can do this surgery by myself and do it very safely. But for a very complex case, it is nice to have another surgeon on hand. It just makes the case go a little bit more efficiently. And, if the patient's getting out of the operating room with 30 minutes less of anesthesia time, that's a plus. They're going to have a better recovery. Efficiency helps with patient outcomes. So I'm a very efficient surgeon in comparison to other surgeons. There are some spine surgeons that should never consider doing a deformity surgery. Surgeries, we try to get these surgeries done in 3.5 to 5 hours at most. Um, but if you have, and some of these surgeries, they're I hear stories from today, modern medicine, where these surgeries are taking 6 hours, 8 hours, 12 hours. 12 hours of under anesthesia is going to lead to it's going to create some issues with blood loss, some complications with anesthesia, and it's going to hinder that patient's recovery. So we're more efficient in the operating room. That's better for patients. And then I utilize techniques that avoid or try to limit the stresses on adjacent vertebrae, particularly in the thoracic spine. So patients tend to develop degeneration next to any fusion that we do. So I utilize a technique that tries to limit the stress at the top of that to limit degeneration, and I've seen fewer problems in my 7 years since adopting um, what we call a soft landing, where we're leaving a little flexibility at the very top of the fusion. So shorter surgery, less blood loss equals better outcomes, my experience. So here's for you that are wondering how we position a patient during surgery. So this is a special operating room table, operating table that we use. It's called the Jackson table. Patients who have pads on, we have it. So their abdomen. So abdomen can hang down. We try to limit pressure on the abdomen to reduce the venous pressure in their body, which can reduce blood loss. So we always try to do these surgeries on special tables. Um, so this is the table that we use called the Jackson table. Here's the navigation system I'm mentioning. So this is what we call the O-arm, which is a device that it opens up after we get the patient positioned, exposed onto the operating room table. This device, this machine can come over top of the patient and do a CAT scan quality study that shows us three-dimensional anatomy, and then it gets fed into a computer program. These are the infrared eyes that are in the operating room that see where our instruments are, and it really helps us precisely place screws. Um, Shortens these surgeries, makes these surgeries much more efficient, and it's reduced blood loss. In my hands, it's cut blood loss by about a third as a result of this technology. Here's the patient being positioned. Oops, sorry about that. Positioned and having the machine do the CAT scan during surgery. And then these are the pictures that we'll obtain from that intraoperative CAT scan. So here we're seeing the bones and the channels. So this is what we call the pedicle, and this is where the screws go down. So that goes through that channel of bone. In some patients, this patient has a nice channel bone at this particular vertebrae, but some patients, particularly with scoliosis, these channels can be exceedingly small. So it helps us find the right channel, maximize the right screw size to put into that channel, maximize the length of screw to get better support in the spine. And then from here, I just basically have a few case examples to show you, and then I'd be happy to take, any questions you might have. So this is a 60-year-old female who came to my practice. She had manageable back pain over the last year. She developed pretty severe pain with walking. So pain with walking to both legs, we typically think of lumbar stenosis. I think I was this patient's eighth opinion. I think she saw 7 surgeons before she saw me, and all 7 surgeons told her fusion, fusion, fusion. Some had debates about how many vertebrae to fuse, from fusing at all over her entire lower back versus 1 or 2 vertebrae in her spine. But she had tried a number of other treatments. She tried physical therapy. She tried shots. She basically tried everything but surgery. So this is her imaging study. So here we're looking at her x-rays. So she has a 30-degree scoliosis, which is a significant scoliosis. So even without surgery, we're worrying this patient's spinal deformity could possibly worsen with time. And then here is her MRI scan. On her MRI, she has what we call stenosis, a constriction in her spine. So the nerves passing through the spinal canal are constricted in this location. This is between lumbar 3 and lumbar 4. Here's a cross section. This shows up above. This is at lumbar 2, 3. We can see each of the nerves, and there's plenty of space. We're here at lumbar 2, 3. There's no space for the nerves. The white stuff up here, spinal fluid. Spinal fluid on these studies is good. Areas where we don't see spinal fluid, the dark area is an area of stenosis. So in looking at this patient study, I felt that we could possibly offer her a non-fusion surgery when we did what's called a minimally invasive or IPSI contralaminectomy, where through a small incision, we're going in and removing, focused under a microscope, we're removing just portions of her lamina, some bone and some ligament, but preserving as much structure in the spine to reduce her risk for progression of a deformity. So we clean out her spinal canal, relieve the pressure pressure on the nerve, which in turn relieves her pain she's experiencing traveling into her legs, but preserve as much structure in the spine so she doesn't develop progression of her deformity. After surgery, she does well. She has most of her pain in her legs is gone. She's very happy, and she has some manageable low back pain, which she's able to deal with. And we've had a follow-up X-ray a year after surgery, and it really doesn't show any progression of her deformity. So I'm hopeful that we've probably bought her at least another 5 or 10 years of flexibility in her spine before she needs a big surgery. This next case, this is a 65-year-old female. She was diagnosed with scoliosis at age 50, and she's had progressive issues with back pain for about 5 years. Uh, she was initially treated by one of the biggest names in minimally invasive spine surgery in the world, with a procedure where they come in through the side, what we call an X lift. And they did this over multiple levels, but unfortunately, she had a lot of complications with this minimally invasive surgery. She ended up with a lung that was punctured, what we call a pneumothorax. She required a chest tube where they put a tube into her chest to reinflate her lung. And then she spent 4 weeks in the ICU with a pneumonia. So minimally invasive surgery, there are some possibilities for minimally invasive surgery for some patients with spinal deformities, but it doesn't always turn out as planned and as advertised. So I would always recommend patients to be cautious of minimally invasive surgery. Sometimes it's best to do an open surgery and get things fully exposed and better addressed. Anyway, so she returned after this kind of nightmare procedure. She presented to my practice 3 months after this first surgery. Here are x-ray, so we can see she has a pretty severe scoliosis. She also has kyphosis, where she's leaning forward. Um, in terms of nerve compression, she really didn't have too much nerve compression in her lower back, but had disabling low back pain. So typically, I would much prefer to operate on a patient with sciatica or nerve pain, but there are situations with severe spinal deformities where we'll consider stabilization procedures to help with an individual's back pain. So I believe I think she was the second patient that I used the spinal navigation for. So in her case, we put screws and rods from her upper thoracic spine down to her pelvic bones. We remove portions of vertebrae here, what we call an osteotomy. We go in and remove portions of vertebrae to loosen up the spine to allow us to straighten it out. And as you can see, she's now much straighter in both dimensions. When you look at her from the front, she's standing straighter. When you look at her from the side, she's no longer leaning forward. And this was a surgery that we performed in 4 hours with fairly low. We were happy with that blood loss. Prior to navigation, the surgery would probably have taken 8 hours, and our blood loss would have been 2 to 3 times that amount. And there have been a chance that the surgery may not have been completed in one day. Sometimes we would stage the surgery where we abort the initial part of it, stabilize the patient, and bring them back a second day to do surgery. But with the aid of navigation, it reduces our blood loss, makes things much more efficient. We're able to get this entire surgery done in a relatively short period of time. And this patient had a great outcome. I followed her for 10 years in my practice. She did very well. She was very happy. Her back pain went away. With some time, she developed some upper thoracic pain above her fusion due to arthritis, but she was able to manage with this pain and has not had any surgeries or procedures since. And I think she is probably about 11 or 12 years out from surgery now. Next example. So this is a case of iatrogenic spinal deformity. So this is a patient that probably had, excuse me, um, a pre-existing scoliosis, and then she underwent 2 laminectomies where surgeons are going in and removing significant portions of bone to decompress nerves. And unfortunately, she probably is seeing surgeons that aren't experienced with spinal deformities, aren't focusing on her spinal deformity. They're just considering decompression of the nerves, and it can lead to a lot of problems. So she presents to my practice after having 2 previous laminectomies. She has back pain and right leg pain. She does have a history. So she's an older lady. She has a history of heart disease. She has a stent. So this is going to be a higher risk patient. She's elderly, and she has heart disease, but her alternatives are not great. She's tried everything else under the sun. She has disabling pain, and here you can see her x-ray. So this is her spine here. So instead of her spine coming straight up, she basically has a 90-degree angle there at the middle portion of her lumbar spine. And she's also very kyphotic, leaning forward. So she's leaning off to the side and leaning forward as she's trying to walk, which produces a lot of back pain. On top, she has a tremendous amount of nerve pain. Here's a CAT scan. So on her CAT scan, we can see that there's no remaining disc in her back. All of the disc here, the shock absorbers between the vertebrae have been destroyed. So this is air where the disc was, essentially bone on bone, every level. So severe spinal deformity, a weakening spine from laminectomy, and severe nerve compression. So in this patient, she has what we call kyphoscoliosis, and then she also has radiculopathy to explain, which is a term that we use to describe a pinched nerve type pain, and that's due to a pinched nerve that's trapped that would provide a sensation to the right leg. She has a issue with balance. So here we can see how she's leaning off here. This is the left side. So on the X-ray, the right side of your body is the right side of the X-ray is the left side of your body. And here we can see how she's leaning forward instead of standing up straight. So this is another case where we use navigation. So we're able to put screws and rods from her upper thoracic region down to her pelvic bones. We do what's called an osteotomy, or remove a large portion of one vertebrae to really loosen things up. In addition, doing laminectomy to decompress the nerves. So this is a surgery that took about 5 hours. We had about 2,300 in blood loss, which is significant. So your blood volume is about 5 liters. But if this surgery was not done with navigation, blood loss could have been on the order of that patient's entire blood supply, 5 liters or more. High risk that that surgery would have been aborted and come back a second day to finish it. We were able to finish it in one day. She leaves the operating room. We take the breathing tube out. She does very well. She stays in the ICU under surveillance for 12 hours. She does very well, and she's discharged to home, and she did very well after surgery, despite her advanced age and her medical risk factors. Next case, so this is another, again, most patients in my practice, probably the average age that we're doing these large surgeries on is mid-70s. I would say the average age probably 74, 75. So this is a 78-year-old female. She's been followed for 5 years. In 2016, when I first saw her, she had a mild pain, but was very functional. Um, in 2019, she developed progression. Then she had issues with pain that went into her right thigh and knee. Pain typically occurred with standing and walking, which is oftentimes the case with a pinched nerve in the lower back. So when you stand up, it changes. The deformity becomes more severe, and the pinching of the nerve becomes more severe, and then the pain symptoms as a result are more severe. And we've tried everything. We've tried epidural injections, so shots of steroids into her spine by non-operative spine specialists. She's had physical therapy. She's done it all. And then she's also seen changes in her posture for the last few years. So here are X-rays. So in 2016, she had a pretty severe scoliosis, but it's gone from what looks like, 60 degrees to probably 80 degrees within 3 years. And then she also has greater kyphotic deformity, so she's leaning forward a lot more, greater extent. So this deformity with the way she's leaning is going to produce a lot of back pain because the muscles have to work a lot harder because of the biomechanics being altered. And then she also has severe nerve pain or sciatica due to nerves being compressed from arthritis and scoliosis. Here's our MRI scan. MRI scan shows multiple areas where there's severe nerve compression. So this is the channel where the nerves are coming down, and we can see compression in multiple spots. So during surgery, we're going to alleviate those areas of nerve compression with a laminectomy, and then we're going to stabilize her scoliosis with screws and rods. So again, a very large surgery. We're performing osteotomies to decompress the nerves and loosen up the spine. And then she has screws and rods placed from the upper thoracic region down to the pelvic bones. So again, about a 4 to 5 hour surgery, fairly low blood loss for this type of surgery. And she leaves the hospital after 4 days in the hospital, which is really good. I usually tell patients to expect a hospital stay on order of 5 to 7 days, especially for someone in their upper 70s. And then here are final x-rays so you can see what we've done for her in terms of her posture. Before, she's leaning off to the left side. Now she's standing straight up. Before surgery, she's leaning forward. After surgery, she's now able to stand straight up, which really improves her pain. So in terms of, just to summarize things, surgery for adult spinal deformity. So it might be the best option for a lot of patients. It might be the only remaining option for a lot of patients. Most patients are going to have fairly extensive conservative treatment, non-surgical treatment before they see me. If they haven't, oftentimes I will start some of those treatments because we want to try everything before surgery. These surgeries can be very extensive with significant risk for complications. I would say that probably 60% of patients that have the surgery are going to have a complication. Most of the time, the complications are very small and manageable from, maybe a urinary tract infection or something like that. But it can also have more major complications. Most patients are going to need a blood transfusion either during surgery or after surgery. But for most patients, we can get them through surgery and get them rehabbed, and their quality of life is going to improve, as a result of these massive surgeries. And I think that these surgeries are best done by very experienced surgeons using the best technology. So, it's really hard to dabble in this type of surgery. So if you're seeing another surgeon and you're considering surgery for spinal deformity, it's important. How many of these surgeries have you done? How many do you do in a year? Are you doing 2 or 3 a year? Are you doing less than 10 a year? Yeah, probably not going to have the most efficiency in the operating room in terms of dealing with that deformity, and may not be experienced in terms of fully addressing the spinal deformity and producing the best outcomes. And then utilizing the best technologies like the navigation system that I've described, that can really make surgeries more efficient. And I think this is all I have. I'm open to answering any questions. If you want to put questions in the question and answer session, we can run through those. Any questions, Melba?
I don't see any questions right now, doctor. I
All
will,
right.
there we go.
Let's see. Kathleen Johnson, I had a cervical fusion. So I'll just comment on Kathleen's, not really a question, but so Kathleen, you're going to have risk for development of arthritis above or below that cervical fusion with some time. So hopefully you get, 5, 10, 15 years out of it before you have an arthritic issue occur adjacent to that fusion. Have you seen success with bracing to help with symptoms? So I am not I am not a big proponent of bracing for most of these patients for adult scoliosis. So bracing to me is best for a teenage scoliosis while the spine is not mature and the spine is growing. We utilize a brace to try to encourage the spine to grow as straight as possible to prevent progression of the scoliosis during the growth phases. Whereas in adult scoliosis, it can be an option, but what it does is wearing a brace results in weaker muscles and can result in more issues. And most patients don't want to wear a brace every time they're up and around. So, if a patient can't tolerate surgery, maybe I would consider a brace. But in most situations, I don't think a brace is a very good option or a very attractive option for most patients with adult scoliosis. So Kathleen, have arthritis, 73. He said, start from top down. I wanted a laminectomy, all lumbar. So I guess it depends on what you're experiencing, Kathleen. So if you have leg pain, it's possible that a focused laminectomy can be considered. If you have scoliosis, I think you need to be very leery of having a laminectomy. You need to make sure that the surgeon doing the laminectomy, one, I think they need experience with deformities. Two, they should try to use a minimally invasive technique that tries to preserve as much integrity of the spine. If they're just going in and doing a laminectomy over multiple levels, they're probably going to weaken your spine and result in a deformity. yeah, I would really have to see your studies to comment any further, Kathleen. So, but if you wanted to contact our office, we'd be happy to evaluate you. Um, Most patients that self-refer or get referred to our office, they're usually going to see a PA that's working side by side with me in the clinic. Um, and they kind of get everything initiated. If you have everything ready at the time of the appointment, oftentimes I will go in with the PA and see patients as well. So we'd be happy to see you if you want to be seen in one of our offices. I will mention I have office in 3 locations. So we have office downtown at the Advent Health Innovation Building. We have Rothman Orthopaedics Clinic at on the Advent Health Winter Garden campus. So right next to Advent Health Winter Garden Hospital, we have an office. And then I also have an office in Davenport. It's not on the Advent Hall of Fame, Heart of Florida um, campus, but right next door. So I'd be happy to see you in any of those locations. You might get scheduled on my PA, but if you do, I am right there with them and can see you at the same time. All right, I'm gonna keep going down the list here. Renee was diagnosed with as a child with scoliosis. She had injections, spine is curved on x-rays, constant pain in my right hip and knee, both hip and knee operations. Yeah, sounds like you have a lot of patients with spinal degeneration, oftentimes also have knee and hip issues. And sometimes it's hard to sort out where the pain is coming from. So pain in the hip could be from a hip problem, can be from the spine. We would be happy to see you in our office. We would want to see an MRI scan if possible of your lower back and look at x-rays to evaluate you and try to tell you where your pain is coming from, what your options for treatment are. And those options within our office can range from therapy to seeing a non-operative spine specialist. I have non-operative specialists that are there in the clinic with me on many occasions. And as simple as my PA might see you, I might see you, and then you might have 3 of us in the room at one time talking about options, and you might decide you want to try the non-operative options first, and we can set you up with one of our doctors that does that, or we can talk to you about the surgical options if we think surgery is a good option or not. How are you addressing the lumbar hemicurve in your patient population? So in terms of curves, we address the curve through a number of different things, through either what we call osteotomies, where we're removing portions of vertebrae or portions of joints to kind of loosen up the spine. We can use, this patient mentions a T-lift. So a T-lift is a support, a cage we put in where a disc was placed. Sometimes we can use that to correct the patient's curvature. We stagger the cage off on one side. So I utilize all those things. So we're using cages to correct deformity. We're using osteotomies to correct deformity. And then we use the instrumentation itself to help correct deformity. Kathleen, you're welcome. Well, thank you again for your attention tonight. I'd be happy to see anyone with spinal deformity. We're happy to see in our office and present options. Like I said, you might get scheduled with a PA initially. Those PAs though work hand in hand with me in the office, and we're going to evaluate things and present you with options. Surgery is not for everyone. If I don't feel like I'm going to make you better with a surgery, it's not going to be an option. I'm going to be frank with you to talk about your options for treatment. What are the risks of those treatments you're looking at? And what is the outcomes? What are the expected success rates in terms of curing sciatica or leg pain or curing back pain? I can't promise that we're going to cure all pain in some patients. So try to be upfront and honest and try not to sugarcoat things.
Thank you, everyone, this evening for attending. And if you have any questions, you can reach out to me. I have put my contact information on the comment screen. And also, if you'd like to make an appointment, you can call 407-852-5333. And I will put that information on the screen as well. Thank you, Dr. Fassett, for this
Thank you,
evening.
guys. Thank you, Melba.
Thank
Have
you.
a good night.
Good night, everyone.